And thank you everyone for joining us again after the break. And thanks also again to the organizers for inviting me to speak. I'm honored to present alongside all these brilliant people from our field. Let me briefly introduce myself as well. My name is Oliver. I'm a researcher with the CT Image Analytics pre-development team of Siemens Healthineers based in Forchheim, Germany. And I'd like to use the opportunity today to take you on a little whistle-stop tour of the places where we see vision playing a role in the CT workflow. And this will roughly make up the first half of my talk. And in the second half, time permitting, I would like to briefly touch upon two somewhat more fundamental, but also very relevant problems that have been subject of a lot of research, and rightfully so. And for each of them, present you one particular approach that we have taken towards addressing them. And these topics are learning from biased data and learning to explain model decisions. Now, starting with the CT workflow, one may be tempted to assume vision in CT is what we do after we have acquired a CT image and I want to analyze it, which is true, of course, but it actually starts much earlier than that. And because there are many steps involved to get a good CT image, and a lot of those we can support using vision. And it already starts with the patient positioning. Patient comes in and needs to be positioned on the table in preparation for the scan. And here, for instance, we have a camera mounted at the ceiling of the scanner room that acquires color images as well as depth images of the patient. And in these images, we automatically detect landmarks and body regions and also the patient orientation, in this case, head first supine, and use that information to indicate the scan range. Also allow the user to interact by manipulating that range, and then also fit an avatar to obtain a complete 3D surface estimation of the patient, so that we have that in spite of foreshortening or occlusion due to clothing, sheets, or other objects, and then use that information to automatically position the patient in the isocenter of the gantry. Now, why is this useful? Well, of course, it's convenient. It's maybe a little fast. It removes unwanted operator variation, but it has a distinct clinical benefit as well, because if you ensure that the patient is positioned precisely in the isocenter, that's basically the optimal operating point of the tube current modulation, which ensures that you get just the image quality that you need with just enough dose that you need to achieve it. Now, once the patient is positioned, typically you still don't acquire the actual CT scan. You would first acquire a topogram instead. And a topogram is basically like a 2D X-ray scan that you acquired with your CT scanner to plan your subsequent 3D scan. You would use it to define the scan range in the axial direction and the recon range in plane. And this again, so here again, detection models can help to automate this task, which is somewhat tedious and again prone to unwanted variation, especially because there's actually a plethora of ranges which vary mildly between all the different clinical indications that you can have. And some are even a little more involved. For instance, if you scan the brain, typically you want to avoid unnecessary exposure of the eyes to radiation, so you would even tilt the gantry. And again, here models can help make that more consistent and reproducible. Then if you need contrast agent, you might want to first have a bolus tracking or monitoring to time the delay right. And then when it comes to the actual scan and recon, besides, of course, the whole field of deep learning-based reconstruction, even with conventional reconstruction, models can help with quality checks. Is my coverage sufficient? Is my image quality sufficient? Do I have enough contrast agent? And then once we have acquired images that we are satisfied with, there's of course a lot of processing that we can do to facilitate reading of the images. First of all, reformatting to align the axis with the anatomy instead of just having scanner coordinates. And then of course, any kind of automatic measurements of organs or other anatomic structures. And then of course, findings detection. And some of these findings, they can even influence what we want to do with respect to the scan workflow. We might need a second workup scan And a typical example for that would be lesions in the adrenal glands. So the adrenal glands are these little hormone glands that sit atop your kidneys, and it's actually quite common incidental finding. I think they show up in around 5%. So these lesions in the adrenal glands, about 5% of all CT scans. Luckily, only very few of these are actually malignant, but to find out, to characterize those lesions, in many cases, you may require a late washout scan, some 10 minutes after contrast administration. And the way this typically works now, if this is not an emergency, is by the time the radiologist gets around to reading those images, the patient is already long gone, right? So what you would have to do is you would have to reschedule a new exam for the patient with all the overhead that is involved. Now, ideally, what we envision, if you were able to automatically detect that right at the scanner, maybe you could avoid that and have the workup while the patient is still on the table, and even guide through that workup. And maybe you could even avoid having to give contrast again. Another scenario that is very important from scanner perspective is emergency imaging. So imagine you have a patient with a head trauma, then you really don't want to waste any time. So you scan their head with a CT, and then it would be ideal if you had post-processing such as a brain hemorrhage detection that runs, so that is linked to the scan protocol and runs immediately as soon as these images are reconstructed, and then also immediately alerts you if it found something, and could then go on to also unfold, for instance, the skull, to facilitate checking for fractures that might be related to that bleeding. So it's really all about workflow. And of course, for emergencies, there's other examples as well. Stroke is a very prominent one. If you have ruled out a bleeding, and what you would typically want to do is assess the parenchyma for early signs of ischemia. And in many sites, that is done with the so-called aspect score, which is basically a semi-quantitative measure of the severity of an infarct. That also helps inform whether that patient is eligible for thrombectomy. And here again, having tools that automatically find these regions and measure them can help to determine that score more reliably and faster. Then there is other emergencies that are somewhat rarer, but also potentially very urgent. If you have, for instance, a rupture of an abdominal organ, the way you would typically diagnose that in CT is by having you would observe little air bubbles that have leaked from that hollow organ into the intraperitoneal space, which we call pneumoperitoneum. And precisely because this is somewhat rare, it may not always be the first suspicion. And then the reading of such cases may be preempted by other more obviously urgent cases. And in this case, again, if we had an automatic detection that runs before the radiologist gets around to read them and could prioritize those cases in the reading work list, that may help patients to have that condition detected earlier. Now, if we have those findings, of course, going one step further, it's also important to characterize them and provide clinical decision support. And this is something that we also would like to empower radiologists and clinicians to find new imaging biomarkers, which is why we developed a do-it-yourself radiomics software that would allow them to manage their studies and patient cohorts and automatically define regions of interest, and then in those compute radiomics features, do analysis, both the statistical analysis as well as machine learning, and do all of that from within one tool with one admittedly somewhat complex but comprehensive user interface without the need to convert data formats or additional coding. This already concludes the first part. So for the second part, I would like to start by talking about bias a little, and this is work by my former student, Simon Lange. And I think we've all seen it reported often enough that many models are trained from data that is too homogeneous, and then those models perform poorly on external data, which also means in practice. And of course, it's very important to carefully validate and to train with more and more diverse data. But there is more to it if the issue is not just that in your sample, the actual input distribution, the real input distribution is underrepresented in some parts. But if the sample that you have also has these unwanted spurious correlations with the labels due to, for instance, some unknown confounder. And in that case, instead of just learning features that don't generalize well, you would be actively learning features that are just wrong. And I mean, there has been a lot of research in trying to detect those biases and model their effects. We approach it a little, and I mean, it's super important, but we approach it a little bit from the other direction by looking at how these could typically influence our images and our models in CT. And what we would typically observe is that we would have some association between the technical characteristics, such as commonly recon kernel or the dose level, with the label. For instance, due to a preliminary diagnosis or even just a suspicion that would inform how that patient is scanned. And to investigate that, we took a data set of lung CT scans, which were labeled, among others, for centrilobular emphysema, and synthetically created such a bias by associating a different recon kernel with the label with a certain probability, and then try to get our models to ignore that, to separate this technical information from the actual biological one that we want to learn. And the way we approached this was by using control regions as surrogates that show only this technical variation, but not the biological one. And we, for instance, just used the air above the patient, which for linear reconstruction would already tell you a lot about the sharpness of the image and the noise level. And what we would do is, if we have a model that works on a region of interest and extracts features to end up at a prediction, we would, during training, feed the surrogate regions through the very same layers. And then at some point, maybe even after each layer, insert this new decoy layer, which would try to determine in these internal feature representations those that are likely to represent technical variation and suppress those. And how does it work under the hood? It basically consists of a correlation unit. And we just use the regular old Pearson correlation, but you could use information theoretic measures as well, or maybe even a trainable component that tries to predict the region of interest from the control region, which it should not be able to do. And then based on that, if you do that over a mini batch, you would have an estimate of the dependency on technical variation. And then we would use that to inform the filter unit and we had good experience with the dropout variant where we make the feature more unreliable, the more it seemed to rely on technical variation. And then during the backward pass, we would actually do nothing to really just push the error tensor through and penalize the preceding layers for extracting those features. And then at inference time, again, we wouldn't have to do anything because all of this happens at train time. So we would already have learned not to learn such features beforehand. And then we wouldn't even need the control regions anymore at inference. Here's some results with a small custom architecture where it's best to show the effects. So the white curve that is a little bit hidden here is our baseline unbiased data and without this decoy layer. Now, if we turn on our synthetic bias, which is the red curve, we can see that the performance drops quite a bit, especially if you look at the adversarial test case where we exactly flip that bias in the test set, where then the model is just consistently wrong. Now, if we turn on the decoy layer, which is the green curve, you can see that we almost perfectly recover that baseline performance. And as a sanity check, if we turn on this decoy layer, even though there is no bias, it behaves virtually the same as the baseline. It does have a few limitations, so we still struggle a little with larger architectures, although we did have better results even with ResNet 18 on Cypher 10 data. It also needs some hyperparameter tuning, which no one ever likes, but at least we try to provide a recipe of how to do it. And while the method itself doesn't really need an unbiased reference set, you would probably still want to have one, because otherwise you'd just be flying blind. You wouldn't really know if it actually works because you have no way to judge. But that really just needs a very small set, right? Because it's not really needed for training itself. And yeah, despite these limitations, we're actually quite happy to see that such a rather simple and lightweight approach was able to cope even with rather strong bias. And for the last couple of minutes, I would like to talk a little bit about model explainability, and this is work by my colleague Alexander Katzmann. So again, this is a huge field, and there has been a lot of work, especially now focused more on thinking about this from the start and not just as an afterthought. But even these conventional saliency maps or attention maps that we all know, I think they deserve some more attention themselves still for medical imaging. And this is where this work ties in. It's yet another post-hoc, but rather model agnostic way of providing local visual explanations for a classifier. And we did some experiments on the LIDC IDRI dataset of lung lesions and a malignancy classifier trained on them. And we saw that several of the popular methods had difficulties producing explanations that were of good quality and consistent. And for comparison, this is what the result for Alexander's method looked like. And it's not perfect either, but it was also, I mean, a lot more in line with our clinical understanding as well. For instance, focusing on the lesion border to explain why, for instance, this lesion is malignant. And so how do we get this overlay? Well, the way it works is by producing counterfactual images of that same lesion. How it would look like if it was more benign according to the classifier, and if it was more malignant according to the classifier, and then visualizing the differences. So how do we obtain these images? Well, it's basically a cycle gun where the domains to transfer between correspond to classifier positive and classifier negative. So for instance, the generator G+ would take any image from our sample X, and there's just this one group, so we're not making use of any labels. It's just all lesion images, and would try to produce a version of it that maximizes the positive class of the classifier that we want to explain. And then, of course, as always, the discriminators are just there to ensure realism, and we use the typical similarity and cycle consistency losses to ensure that all the changes that are made are relevant to the actual decision. And the explanations created in that manner were rated superior with respect to several criteria. Admittedly, it's a rather heavyweight approach, training a whole cycle gun just to explain your classifier, but I thought it was a clever idea, and maybe it helps inspire new approaches as well. So to summarize, I hope I was able to show you that we can use vision to make the whole CT workflow not only faster, but also more reproducible, and also ensure that we get results that are consistently of high quality, and that these broad issues such as bias or model explainability can have very specific aspects in medical imaging that then also benefit from much more tailored solutions. So with that, I would like to thank you for your attention and happy to answer any questions.